Hi, and good afternoon. Welcome to Altarum Center for Value in Healthcare's webinar, where we will talk about the many factors contributing to low-value care, present a comprehensive framework for understanding and addressing it. I am Beth Bowden-Seiler, and I'm from Altarum Center for Value in Healthcare, and I'll start off the webinar by briefly presenting the work that Altarum has done in this space, and then turn it over to my two co-presenters, Neil Shah and Beth Bortz. First, a little housekeeping. Your lines are muted, so only the chat function is available. We have an hour today, but we would like to leave time for questions. If you have a question, please type them in the chat box, and we will get to as many of these as we can. So let's get started with the framework discussion. We are all probably familiar with the concept of low-value care, but understanding where value is leaking out of your system is very complex. Value leaks out of the system in many ways, including low-value care, in which the benefits are marginal, negative, uncertain, or in this example, unnecessarily duplicative. It includes medical harm and error. It encompasses pricing failures, which are those unexplained variations in costs for services. And it includes the underuse of high-value care, such as missed flu shots. Through a grant from the Robert Wood Johnson Foundation, Altarum Center for Value in Healthcare took on the development of a comprehensive approach to measuring low-value care, specifically in the area of overuse. For us, developing something comprehensive meant being able to measure services using an additive approach as well as a comparative approach. The additive approach allows us to examine services such as those in Choosing Wisely recommendations that may be considered low value in certain circumstances. We can apply algorithms codifying low-value care to the services using claims data to measure frequency and associated costs. But we know we can't do that for every service that's identified as potentially low value. Some services do not lend themselves to being measured with just claims data. The clinical nuance is not there, and so we must take a different approach to those services. That's where the comparative approach comes in. In the comparative approach, we measure the frequency of per capita use for the identified service and compare that across a study group looking for excessive usage and potentially low-value care. In this approach, we cannot definitively say the excess is low value or wasteful, but it offers us a red flag to examine those areas more deeply as to why they are in excess. For example, in the additive approach, we can add up the services and associated costs that are not recommended in the management of patients with a certain condition. By including both inclusion criteria and exclusion criteria, we can filter out those patients that received a service appropriately, leaving the remainder to be highly likely wasteful or of low value. In the comparative approach, we can identify a benchmark service level, such as a leapfrog national target rate for a service, measure the frequency of the service, and anything in excess above the target can be flagged as potentially low value for further examination. In our methodology, think of the comparison approach as the 40,000-foot view, where we can see broad areas of what might possibly be waste, whereas the additive approach is more definitive and allows us to go into details of particular services and identify what is in fact low-value care. The method was developed to examine overuse, but could be applied to any of these sources contributing to low-value care. Next steps for this comprehensive approach are to define calculations, conduct alpha and beta tests with partners, and create an index to compare the rate of low-value care by various categories. So with that, let's turn things over to Dr. Neil Shah to discuss the many factors contributing to low-value care. Dr. Shah is an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School. He founded Cost of Care, a global NGO that curates insights from clinicians to help deliver systems provide better care. We'll turn it over to Dr. Shah.
Thanks so much, Beth. So, as Beth mentioned, a professor at medical school and School of Public Health, but I also am an obstetrician and I work clinically. So I spend like 20% of my time or so seeing patients, and the way OBGYN is that you get a pretty broad purview over the healthcare system, because a lot of what I do is preventive care, but I also deliver babies and perform surgery as well. And when I'm not seeing patients, my job is largely to kind of forecast and prognosticate, which can be dangerous, I suppose, and maybe even evangelize a little bit. So that's really almost a disclaimer, given that I think, I'm going to just try to be a little bit provocative for 10 minutes or so, and then turn it over to Beth from Virginia, who's, I think, much more grounded in the real world, and will tell you about all she and her colleagues have been able to accomplish there. But I guess the first provocation is to tell you that I think 2018 is the least affordable that healthcare has been for the average American in the last half century. And that's really the context in which all of the work that we're doing is happening, and it's the context in which Costs of Care, the nonprofit, exists, working really hand in hand with the Choosing Wisely campaign to try to engage clinicians in the effort to improve value. The fact that it is the least affordable that healthcare has been for the average American in the last half century is why it's a dominant part of the political discourse and the public discourse right now. It's also the burning platform, I think, for engaging in value-based care, and also maybe even expanding the notion of what value-based care even is in 2018. So I guess the first idea that I wanted to throw out there is that as a clinician in the trenches, there are multiple forces that are converging right now that make value-based care part of my consciousness, even on a day-to-day basis as I'm seeing patients. The first is this idea, of course, of the eroding affordability for even routine encounters. So we all know that we've been working on expanding coverage for a while, but even when you've got coverage, coverage is increasingly spottier. It's not just that premiums are going up, it's that deductibles are also going up. And there are multiple means by which you can find yourself really exposed financially or just in the lurch. So that's going on. At the same time, there's been a lot of effort, particularly over the last, I'd say, 5 years or so, to really drive accountability for the total cost of care within healthcare systems. So it's not just the bottom-up pressure that I'm getting from the patients I'm seeing, it's the top-down pressure that I'm getting from the system to measure outcomes and measure the quality of care that I'm delivering. Now, all of this is happening in a context where, the reality is the last really big concerted effort to sort of manage the delivery of care was in the 90s, where the internet was AOL, and AOL CDs being snail-mailed to you. Whereas in 2018, we're managing care in an environment where there's really radical transparency over every other commodity in the marketplace. So from Travelocity to Yelp to Amazon, there's sort of an expectation that we ought to be able to see quality and price when we transact. And healthcare has never really been that way, but there are tens of billions of dollars right now in the Silicon Valley to make a Yelp for healthcare something functional. So that's going on. The fact that if you were to Google any clinician, the top hit would not be their profile on, even if they work at the Cleveland Clinic, it would be, 2 hits of physician rating sites. And then the other sort of parallel reality that we're living in is really for the first time, we have technologies that are being deployed into the marketplace that are not only extremely expensive, but also extremely worth it. So, for example, we've got a medicine that can cure hepatitis C and is more cost-effective than a liver transplant, but is $100,000 for a treatment course and is utterly unaffordable for an individual and really strains even what the budget of a large payer, like a state payer, like a Medicaid can cover. So those are the forces that are converging in the marketplace right now, and what we're feeling in the trenches and taking care of patients What this really means for me as a doctor is that I'm seeing 3 distinct failures at the point of service. So the first is that when my patients come to me and they're concerned about what their care is going to cost them relative to what they're going to get out of it, the first failure point is I really can't tell them what any of my recommendations is going to cost them out of pocket, right? So there's like failure to be able to give people a sense of what things cost at the point of service. The second failure, which is the one that I think the Choosing Wisely campaign was really well and has been really well set up to deliver on, is that I can't really often tell them whether or not things are worth it. Actually, I probably can tell them whether or not things are worth it, but as the Choosing Wisely campaign has demonstrated, we often don't disclose whether things are even worth doing in the first place, and there's a lot of low-value care that falls into the waste category. The provocative idea I want to throw out there is based on this third failure, though, which is that sometimes things are both expensive and worth it, and increasingly so in 2018, both because of these technologies like the hepatitis C drug I mentioned, and because deductibles are rising. And when things are both expensive and worth it, there are often lots of options that we can take advantage of to help make care more affordable for patients, help them comply with our recommendations, and ultimately help them get healthier that we just don't end up taking advantage of. So that's really that third failure. And what that means is, by the way, I only have 1 graph, I think, and 3 slides, but this is one of them. And what this is graphing is the difference between the total cost of care and affordability. So that white line there is the growth of cost as a percentage of GDP. And this is the thing that, you know, we've basically given up on reducing, but we're just trying to bend the curve of, right? That's the white line. And that's what everybody has been laser focused on, is total cost of care. But something that's always been apparent for me and has been the driving motivation for cost of care is that there's no doctor that goes to medical school to treat the GDP. And at the same time, the blue line is happening, which is the percentage of total household income going to healthcare. And what that line is really showing is affordability. And interestingly, in public policy circles, affordability isn't the thing we're trying to bend the curve of. It's the thing that we're actually trying to tamp down. And yet it's growing much faster and is a much larger proportion of household income relative to total cost of healthcare to the GDP. So these are distinct things. And I think what that means for us is that we have to think about, the next step after Choosing Wisely. And what Choosing Wisely has done has helped move the organizing ethic of medicine from being about thoroughness, which was what I was taught was my aspiration in medical school, to appropriateness, which is a better aspiration. And that was what we've gotten to in 5 years, is that that's actually the organizing ethic of what we're all trying to do now. Implementing that and actually making it a reality is obviously something that requires further work, but at least we understand what the goal is. We have goal clarity. In the next 5 years, what we need, though, is not just appropriateness, but appropriateness plus affordability. And I guess the provocation that I want to throw out there is that we often define value as being outcomes over cost, but I think that there's an opportunity to create a parallel definition of what value means at the individual patient level. And, at the health system level, we talk about total cost. At the patient level, we talk about affordability. At the health system level, we talk about quality. At the patient level, we talk about safety. And ultimately, what patients care about is the affordability, the safety, and the experience of care, which to them is really the personal nature of care. And what we're seeing right now in delivery systems, and what I think is really the large challenge that I want to set up for this audience, is that these are really separate work streams right now. There's a financial workflow in the delivery system, there's a clinical workflow, and then there's a theoretical experience of care workflow, although that's largely been an afterthought in healthcare. And what I'm really interested in trying to push our industry towards really thinking about is how to bring these workflows into concert and coordination. In terms of actually making that happen, we're in the early stages working with the AVIM Foundation and other partners and just trying to create a mental model of what this really means. And, the need to attend to value at the patient level or put resources into it or to exert effort to try to fix it is based on some combination of a patient's financial exposure and their level of activation or agency, or their ability to do something about it. And there may be multiple touch points in a cycle of care where we can engage somebody in, whether it's pre-encounter, during the encounter, or after the encounter, in trying to help them manage the affordability of care and really activate resources that exist within the delivery system and even within the community more broadly to help them, which can include anything from social work to elder services to simply just thinking about not only which care we recommend, but where they get the care and when they get the care. So that's really what I had planned to say, and I'll turn over to Beth now, and we'll look forward to questions afterwards.
Thank you so much, Neil. That was great. We're going to turn things over now to Beth Force. She is President and CEO of Virginia Center for Health Innovation, to discuss efforts there to analyze and address their low-value care. Beth, I'll hand it to you.
Great, thank you. Can everyone hear me okay? I want to share with you a little bit about our experience in working to reduce low-value care in Virginia. So I've put here 5 kind of key steps in the journey so far, and I'm going to talk a little bit about each of them. Really, we started with the need to build consensus around choosing wisely principles. We moved then to leveraging our data from Virginia's Allpayer claims database. And in Virginia, we applied the Milliman MedInsight Health Waste Calculator, trying to identify which medical tests and procedures we should work to reduce. We then worked to share our early data with partners to test the validity and acceptance. Then we worked to build consensus and focus. And then finally to identify and test multiple improvement strategies. So let me give you a little bit about each of those. So coming into this, I think I should set the stage that Virginia, some of you may know, is what I call a purple state, in that we flip our political loyalties from election to election. We typically have an executive branch and a legislative branch that are at odds. We have not expanded Medicaid, and yet that every General Assembly session is kind of the biggest issue. And so when we were looking at the Virginia Center for Health Innovation to what could we work on together that would not be in the toxicity of what healthcare policy had become, I started to sense that we could build good consensus around the value of healthcare and really trying to both improve high-value care and reducing low-value care. And we started with reducing low-value care because we knew that if we didn't identify some financial resources to do this work, if we couldn't go to the high-value care side. The state wasn't going to put more dollars in on the front end. So we really started with reducing low-value care. And you'll see on this slide here, I started with just a lot of conversations. I went and started meeting with some of the key players to make sure that they were supportive of this idea. We really were very engaged in the ABIM Foundation's Choosing Wisely concept. People liked that idea. We liked that it was physician-driven. And so you'll see here, medical specialties, but also working with our State Chamber of Commerce, our Hospital and Healthcare Association, our health plans, health philanthropy. All of those folks became kind of early stakeholders in the conversation. Once we kind of had buy-in that this was something that folks were interested in moving forward on, we then wanted to get to the data. I'm a big believer that, if you don't understand the data, you can't fix things. And so we were very fortunate in Virginia that we have an all-payer claims database, and that in our case, Milliman, who is the backbone for our state all-payer claims database, had developed something called the waste calculator. And so we were willing to be one of the early guinea pigs, if you will, of using that waste calculator to look at our data. So just a little bit about our Allpayer claims database. Virginia has a little over 8 million citizens, and our Allpayer claims database is a voluntary one, which is unusual, but we had data in there from more than 5 million Virginians, including our largest health insurers, our Medicaid fee-for-service, and the Medicare fee-for-service. So you'll see here, just give you kind of how we defined low value. We really used, services that had no value in clinical circumstances and could lead to unnecessary patient harm, and looked at evidence-based guidelines. Our results are very conservative in nature. So here you'll see data from 2015, which we made available in January of 2017. We actually, if you're interested and you look back at our website in about a week, we will have the 2016 data posted. But we looked at 45 different tests and procedures, and you'll see that we identified 1.66 million low-value services were provided that could have yielded potential savings of $593 million. So when you start a report with these numbers, you get attention. In our state legislature, across different groups, people started saying, we want to learn more about this. So a little bit more detail. We found that of those 5 million Virginians, about 1 in 4 were exposed to an unnecessary service. 34% of the services measured were considered to be of low value, and almost about $10 per patient per month was being spent on low-value care. You'll see here, I just give you a snapshot of the top 5 measures by cost. What I will share with you, and I'll probably talk about this a little more in a minute, but I share this for you, but I've learned that we don't lead out of the gate with talking about cost. We have been far more successful when we talk about both cost and harm. And so in Virginia, we're actually, as we begin to wrestle with prioritizing things, we are considering the potential harm equation as much as we are considering the potential cost piece. We also found that the provision of low-value services varied fairly significantly by region of the state. And if you don't know Virginia very well, Northern Virginia is our wealthiest and heavily populated, heavily educated portion of the state. And they are also the biggest offenders, if you will, of providing unnecessary care. So as we looked at that first year of data, I started to go out and do a roadshow and try to test the validity. I wanted to hear from folks concerns that they had. And so I've shared with you here just a few of my findings. One, physicians in particular do not like the term waste. So we have tried very hard to use low value or unnecessary care. Waste can hit a nerve. As I mentioned earlier, we try to focus on the harm piece first, not just focusing solely on the cost savings. In our data, we have we're able to look at what is called the waste index, and what the waste index, in simplest terms, is how frequently is the service provided considered to be of low value. Because one of the things I want people to understand is that the same service can both be of very high value to one patient and of low value to another based on their medical history and clinical circumstances. So this is all very clinically nuanced. It's, I tell people, it's if A and B and C, then you shouldn't have had D. And so, the data set needs to be rich enough that you can get all of that information. We needed to be sure we had a multi-year look back in claims data to be able to determine some of this stuff. But also, some of these services are just of low value all the time. And so the message we got from our providers and our health systems was, don't pick things that while they may lead to a high cost, 97% of the time providers are getting it right. That is going to be hard behavior change, as opposed to choosing something like vitamin D screenings, where we shouldn't be doing them all the time. And that's an easier behavior change to make. And then we learned in the roadshow that we have to be prepared to address providers' medical liability concerns. And we really need to make sure we understand the need for consumer education, because our providers are put in a very difficult situation when the patients that they are treating believe that more of anything is always better. So moving forward in building consensus with our data, we have 3 strategies that are in place right now. We're working with an emerging national task force on low-value care. We've begun to establish a Virginia Health Value Dashboard, and we are initiating pilot projects with some interested partners. So the National Task Force on Low-Value Care, this is a multi-stakeholder effort that was established by VBH Health at the University of Michigan and is spearheaded by Dr. Fendrick and Michael Chernew from Harvard. And as you'll see there, the mission of this task force is really to draw attention to research on low-value care, to disseminate effective practical tactics, and to identify and prioritize strategies for impacting state and federal policy making. At the meetings, we've had 2 meetings of this group so far. A 3rd meeting is scheduled for March of this year. But in the first 2 meetings, we really agreed that even Virginia's data, which was kind of used as a baseline for these meetings for folks to look at, 45 tests and procedures is too many to tackle effectively out of the gate. And so the group spent its entire 2nd meeting looking at developing a top 5 list, 5 things that we wanted to work on. And you'll see here, I've listed for you the top 5. And number 1 is clearly number 1, because when you look at the data, the magnitude is significant, and that is unneeded diagnostic testing and imaging for low-risk patients before low-risk surgery. I also mentioned vitamin D screening, PSA screening in men 75 and older, imaging for acute low back pain during the first 6 weeks unless there were red flags present. And then the 5th one, which is actually one that Virginia had not looked at, but the larger national group felt was very important to include, and this was avoiding the use of more expensive branded drugs when generics with identical active ingredients were available. And so I mentioned to you that next week our 2016 data will be available on our website. We did run 2016 for the 4 that the waste calculator could do for us. And I just wanted to give you a sense of the numbers. And again, when you look at those, you'll see why I mentioned that number 1 really is number 1, the diagnostics and imaging for low-risk patients before low-risk surgery. So we had all that data and we had all that information, and that prompted a larger conversation in Virginia about a health value dashboard. Our key policymakers said we really need to know, how are we doing at moving our system of care from one that pays for volume to one that pays for value, with reducing low-value care being a piece, but certainly not the entirety of what we care about in the Commonwealth of Virginia. So we brought together about 60 different organizations and stakeholders across the Commonwealth. We agreed on 3 aims: reducing low-value care, increasing high-value care, and improving the infrastructure for advancing value-based health care, with a focus on data infrastructure, health information exchange, value-based payment models, and investment in population health initiatives. What you will see before you will not be the final version of our dashboard, but I wanted to give you a sense of what folks are talking about. I will tell you my job has been to be kind of the bad guy in terms of keeping folks to under 10 indicators Every time we get together, there's a ton of indicators that people want to discuss and include, but a dashboard by its very nature should be one page. It should be something that's manageable and that we can really be working to impact. And so right now you'll see we have 3 proposed indicators under reducing low-value care, 3 under increasing high-value care, and then 3 under improving infrastructure. And the second one under AIM 1 gets really to the reducing low-value care as captured by our data. And so now there is a great deal of conversation and activity in our state around beginning some pilot projects. Our state employee health plan, we were able to run their data separately so that they could actually look at their performance. And they are very interested in looking at potential benefit redesign and their new contracts when they go out for bid later in 2018, reflecting the need to improve in some of these areas. Our federally qualified community health centers actually approached the Virginia Center for Health Innovation, asked if we could create mini dashboards, if you will, for some of their sites. If we could run their data on low-value care through separately so they could really start to examine it and develop a plan for improvement. And we just last week gave 3 pilot sites their data and are beginning conversations with them about what they might want to do. We did recently submit in partnership with several of our academic medical centers and health systems, as well as ABIM, a PCORI submission, where we look at 2 comparative, a comparative effectiveness strategy about what works, so we can get a handle on what method really works to improve care. And then finally, we've run the data for our state Medicaid agency, and they are also looking at that closely and trying to decide what steps they want to take. And so with that, I will turn it back over to Beth.
Thank you, Beth. That is wonderful, wonderful presentation. Let's open things up for questions. Remember, your lines are muted, so if you have a question, please use the chat box to submit it. And we do have a question here. Beth, this is going to be for you from Megan. What criteria were used to choose the top 5?
Sure. So we looked at several different factors. We looked at the cost data and the frequency data. We wanted to choose things that if we did less of them, it would make an impact, a meaningful impact. We looked at harm as a factor. We looked at what I mentioned was kind of the waste index, and that is how frequently are providers getting it right or wrong. And so we didn't want to choose the needle in the haystacks, if you will. We didn't want to choose things that, even though the cost might be big and even the harm might be big, 97% of the time folks are actually getting it right. We figured behavior change would be hardest there. So we kind of had those different criteria in our mind when we looked at the data.
Wonderful, wonderful. The idea that Neil was talking about of merging together affordability and appropriateness is quite interesting. And so, Neil, this question is for you. What is the first step that you think healthcare systems and providers could do to help start thinking about affordability and appropriateness together? You mentioned that Choosing Wisely has done a good job of getting providers to start thinking about appropriateness. What do you think it's going to take to get them to start merging together this affordability piece and in with it?
Well, I think one thing that I think would be helpful to all of us is probably conceptual clarity about the fact that cost and harm are not mutually exclusive. I think that we're actually, part of my provocation is that 2018 is actually a very different moment than 2013 at the beginnings of the Choosing Wisely campaign, where Choosing Wisely was very intentionally branded. There was a lot of concern that if we were to think about value or cost, that we'd be skimping on necessary care, or at least it'd be perceived that way. But I think we're at a moment actually where the overwhelming majority of the patients that we see in our clinics, and this has been validated by multiple national surveys at this point, both want and expect their clinicians to be able to engage with conversations with them about, basically their wallets in very explicit terms. And so I guess one, I think, thing that we can do just conceptually is just not separate the ideas of cost and harm and actually think about financial harm as an important form of harm, and then to develop ways of tracking it, and then to really be proactive, because usually what happens is, you declare your insurance coverage at patient intake, and that's totally decoupled from the clinical encounter, and then weeks later a bill is generated and sent out, and that need not be the case. And increasingly that's going to matter not just reputationally for delivery systems, but it's going to matter in real time in clinics as we're trying to deliver care, because patients are honestly bringing it up.
That's great. That's interesting. I think that ties in really well with something that Beth had said in her presentation about what they had learned about the roadshow that she was doing and how to speak to providers and clinicians on using harm first rather than cost. So Beth, can you maybe touch a little bit more on what has been some of the most challenging parts of addressing the findings that you've had in Virginia with clinicians and providers, understanding how to talk about harm first and not cost?
Sure. So, I will say that my very first lesson was that the very first presentation I did with the data in a room full of physicians, I started talking about waste, and I lost them. They got so upset with the concept that of defending that they weren't being wasteful that we couldn't really get into the meat of the data. And so several of them afterwards I talked to, and follow up, and they shared with me that, they know there are things that they do that are unnecessary. That was the whole idea behind choosing wisely. But that there's a variety of reasons why they do those things. And that if we could really reframe it as a conversation, a partnership about how do we do better at both identifying and agreeing that we want to do less of this, then the whole tone changed, and they became very engaged. I found, and this is not surprising, the literature bears this out, but a lot of times it will take a provider looking at their own data and really doing a deep dive. And we've actually started to do this with some of our sites where we get their NPIs and we run their data specifically through the Allpayer claims database and the waste calculator. And they start to look at it and they realize that they are doing more of some of these things than they thought. And then they become much more engaged in what kind of systems. And the ideas range from having, patients in their practice engage in patient councils to help them think about how they message to consumers, to EHR alerts to make sure that they think twice before ordering some of these things, to continuing medical education on how the guidelines have changed. One of the things that I usually use as an example for folks is that the recommendation around pap smears changed years ago, where unless there are red flags present, a healthy female does not need a pap smear every year. It's every 3 years. But there are a lot of providers that are just doing it every year because they've always done it that way. So we've really worked to get them to be part of the solution finding process, and that has been effective.
Wonderful. That's wonderful. We both talked about the piece of value in healthcare. There's a piece that's high value, and that we do want to do more high value care. We have a question here. How can payers contribute toward enforcing high value care? And I would ask that of both Neil, you and Beth, to weigh in on how you think, how can payers contribute toward enforcing high-value care?
I can try to take a stab at it first. You know, payers clearly have a very important role to play in both. You know, I think there are multiple points. I think one is in just design of the products, in trying to make sure, you know, because I think payers often have purview and line of sight over the variation in a marketplace, which is considerable. One of the lowest value things that we do in obstetrics, ironically, where there's the most variation, is the most common major surgery performed on human beings, which is cesarean deliveries. And it turns out the biggest risk factor for the most common surgery performed on human beings or Americans is not personal preferences or medical risks, but it's literally which facility you go to. So I think that, you know, designing products that really try to point or steer people, consumers, patients towards places that are doing well and delivering on value is certainly one way. And there are many other tactics as well. I think, though, that one thing, and really my perspective here is as a clinician, is that there's often a little bit of an adversarial relationship between clinicians and payers, and I think that need not be the case. And I think the more that payers can do to try to proactively reach out to clinicians and fold them into the way that they're being measured, to really engage them as thought partners, particularly around affordability, because I can't emphasize this enough. Like, nobody goes to medical school to treat the GDP, but each and every one of us cares very much about, you know, inadvertently hosing the patient in front of us. And I think there's a really important opportunity for partnership there.
Wonderful. Beth, thoughts on how can payers contribute to enforcing high-value care?
Absolutely, and I think that's a really important piece, because when I started, I mentioned, you know, we've always had in Virginia the goal being both to reduce low-value care and increase high-value care. And it was very important in those early conversations with our clinician community that this wasn't just going to be all about reducing low-value care. Because let's remember, there is a financial element to all of this. And, you know, some of the early meetings I had were with health system chief financial officers to say, you know, realistically, are you going to join in on this campaign if, you know, let's see what's going to affect the bottom line of your organization. And, you know, I was very encouraged that folks wanted to do the right thing, but they wanted to do the right thing even more when we said we also want to increase the provision of high-value care. And so when you look at the payer piece of that, part of the reason we've been working on the health value dashboard that I mentioned is that payers have the ability to incentivize clinicians to do things. But one of the challenges that I see out there is that, you know, I'll give you an example. We pulled the contracts for just primary care in the Commonwealth in Virginia and looked across every health plan contract, and if you were participating in all of them, all the incentive-based ones, you had to report on more than 500 different metrics. You can't move the needle on 500 metrics. You can't focus on improving high-value care when you're reporting on 500 things. And so we've really been imploring our payers in Virginia to try to come to some consensus on a handful of things. And that's really the idea behind the dashboard. And they have been part of every conversation about which indicators we choose, because we think if we can get consensus from them, that we will see real change in the marketplace.
That's wonderful. Thank you. We have a couple more questions. Again, we have a little bit of time left, so if you have a question, feel free to drop that into the chat box and submit it to us. But I do have a couple of questions left for you, Beth. You mentioned that one of the concerns when you were on the roadshow was how to address provider medical liability concerns. Obviously, that would be something that providers would be interested in, you know, when you're talking about reducing low-value care services or talking about reducing services. How did you guys address their concerns on provider medical liability?
Well, the truth is we're still working to do that. We haven't mastered it yet, but I will tell you, you know, when we looked at the recommendations, you know, these are the things that we chose, that Choosing Wisely chose, or that the U.S. Preventative Services Task Force chose. You know, there is solid, you know, evidence-based science behind these. And so we have met with several attorneys who have assured us that our clinicians here in Virginia would be protected if they are following evidence-based guidelines. That being the case, there's still the perception, and you know, perception can be reality. The perception that if I don't provide this screening, you know, and something, you know, happens several years later with my patient, they're going to come back and sue me. And so we've really been working to try to figure out, you know, how can we reassure clinicians that they will be protected, and that's an ongoing battle for us.
Understandable, for sure, for sure. My last question, back to you, would be, do you think that Virginia has a unique culture that it allows it to be able to address these issues in this way? You did go through a great list of the things that make Virginia stand out as far as what makes it up. What do you think is so critical in being so successful so far in being able to address this?
You know, I would say if we can do it, anyone can do it. I don't think our unique cultures made it you know, either. I think we have a very challenging culture in that, you know, we don't have agreement on healthcare. You know, we struggle with everything, and this has been something that pretty universally folks have agreed upon. We also have a voluntary all-payer claims database. Many states have mandatory APCDs. So the fact that we can do this, I think many states could do this. I think many large employers could look at their data. I think plans could be looking at their data. I think health systems could be looking at their data. You know, I think we just are the tip of the iceberg, and I think part of it was because necessity is the mother of invention. You know, we needed something that we could get people to agree upon.
That's great. That's great. Thank you for that. Neil, we have a question for you from Monica. She asks, when will we see consensus around affordability metrics, similar to the quality metrics that health systems capture and report?
That's a good question. I think that we'll see consensus after we take the first step of deciding that there's a need to do it. And I think that that's going to happen because of, I just can't emphasize enough how disruptive to everything that we're doing now the eroding affordability of healthcare is likely to be, particularly given the current political context where there's not a way forward from the Affordable Care Act. In fact, there's, as we all know, continued instability in the marketplace. So I think, you know, what we need is an innovator and a market leader to take the first step of at least trying to track affordability within the boundaries of a delivery system, and then hopefully others to follow the lead. And with all of this work, you know, the honest truth is we're all trying to find our way forward, including the clinicians. And I think, you know, there's a lot of conventional wisdom about the way clinicians think. For example, clinicians are worried about medical malpractice. They're risk averse. But I think just like it's important not to paint all patients with a broad brush, it's important not to paint all clinicians with a broad brush. And when we're thinking about our audience, we always want to be mindful of the laggards and the really recalcitrant docs that are likely to be out there, and make sure that we're sensitive to that and we're acknowledging that they're concerned about medical malpractice and other concerns that they might have. But I think in designing our solutions, we should assume that we've got well-informed and well-intended partners, and really try to move the innovators and the early majority towards the right thing to do. And then others will follow suit, which is what we've seen in every other important, basically initiative that we've done in patient safety and other areas of healthcare improvement, including the Choosing Wisely campaign.
That's wonderful. Well, thank you so much. I think that is a great way to end the webinar, a great note to end on. I want to thank our co-presenters, Neil Shah and Beth Bortz, for your time and all of your insightful comments today. It's been fascinating listening to you and understanding what you all are working on and talking about and thinking about when it comes to value in healthcare. Thank you for everyone that has joined us and listened today. If you have any questions, please contact Bill Hicks at Altarum. And please complete the post-webinar evaluation and download a copy of today's slide presentation. Thank you so much and have a wonderful afternoon.